I was thinking of what constitutes a good doctor, so I'm just picking up this weekend some shifts because somebody's out. And it's like, there's no perfect doctor, right? I think that's easy enough for those of us who have worked for a while to accept. And certain people are good at this, better at that, not good. But is there a perfect doctor? Are there always things people are better at and things they're worse at? So there's a guy, high up in administration, and I was looking at his notes, and they're pretty good, right? Yeah, addresses all the problems, etc. But then on one of them, you wrote something that's not consistent with what's actually being done. That the patient actually doesn't have anything being given for bowel movements. He's constipated on lots of narcotics, which is lesson number one when giving narcotics. Make sure if your right hand writes the narcotic prescription, the left hand writes the stool softener, right? Patient hasn't gotten anything. So the note is inconsistent with what's actually happening in the patient. And then the second thing that I find interesting is, in terms of good, right? What is good, right? Medically good, spend time with patients, they like you. It's all very difficult to distinguish, to delineate, to separate, if you will. I just spent time having a long conversation with the patient and her family. Well, where do we go with all this? I was told to, yeah, try to, maybe if she could change to be DNR from full code. And so in that sense, you could say goal accomplished. But that's not really my goal. My goal is to figure out what she wants, right? Talk with her family, do my best to help her make a decision. And if you think about it more, I would say, right? What is the goal? Because I'm staying late and I get paid hourly, so I'm going to bill and I make more money. But realistically, if I make her DNR and it saves the hospital lots and lots of money, then it's a net win, right? What is the goal in clinic? As I'm doing more clinic, I'm thinking about this more, right? Are we in the business of population management? What does that mean, right? In clinic, I feel like at most big HMOs, you are in the business of population management. You're not about taking care of people to the best of your ability. You're trying to just take care of the average person. Do just average for them based on cost benefit, money analysis, if you will. In the hospital, I thought it was different because we try to take care of our patient to almost the exclusion of other people's. We don't care if we're stealing other people's resources. We want our patient to get the best possible care. But is that true? I was asking a colleague about a medical question. I was like, I feel a little sort of hesitant. I might as well ask a colleague. I was like, the risk is low. I mean, the patient's younger, so that's bad if he does have this. What should we do, right? Should I let him go? Should I not? It's all, I would say, a very good question, right? Which goes back to the whole thing is this prior doctor I picked up after, he catches a lot of things that I might have missed. But then there's some things that maybe I caught that he missed. Is that the way it always works? Is there a perfect doctor who always sees everything? Is it important to address all the issues as many hospitals do nowadays? I would say no. Not important to address all issues. It might be important to know about all the potential issues, so if something comes up, you can figure it out. That's important, I would say. But that's not the same as addressing all the issues. Taking another level, is it important to get the right medications on board when they're in a hospital? Or is it just some bandages, this, that for blood pressure, willy-nilly throw it at the patient? Because there's actually a rule and a regimen and a methodology to doing blood pressure medications. There are certain medications that are better for you, realistically. They help your kidneys, some protection for your heart. Other ones control your number, but don't do that. Wouldn't you rather be on the ones that do? There's some medications that potentially increase your risk of harm, like beta blockers. You may get diabetes earlier. Isn't that a bad thing? They may control your blood pressure, but isn't that a bad thing? If you don't have a reason to be on it, shouldn't you be switched off? Or it's too complicated in a hospital, just have your PCP do it. Also doesn't have time. Is there a right way to do things? In the hospital, many times we order medications that are given quite a few times a day. That's sort of impractical for a patient to do it at home. We change it over to something else. Oftentimes I use short-acting metoprolol. But we all know when sending a patient home to convert to long-acting, except for the doctors who don't know. That means it's important to know what happens afterwards. To know a little bit about the other side so you could prepare for the other side. But all these things are hard. There's doctors who work in a clinic and work in a hospital and technically should see both worlds. Are they better though? Are doctors who see adults and kids better? They should know more. Med Peds, internal medicine and pediatrics. Great, right? Family medicine. Well, maybe that's too broad because Med Peds, they have, 4 years compared to, 3, so an extra year. And then, family medicine is just 3 years. So they don't really have time to learn everything. So they're not good at it. Well, if you look at the studies, where is Med Peds better? Not much really. Maybe adolescence, that transition period. Because I don't think realistically it makes a difference when you start calculating dosages based on weight for adults. You think it might, but I don't think practically it does for stuff we do. But here's the thing. Is it all dependent on the patient? What doctor is better? Can you make a real serious argument that if the patient likes the doctor, that's good enough? Even if the doctor is not medically good. If the doctor makes wrong decisions, they're just like a friend in the medical field. Is that truly what we want? Or are there basic guidelines? Does it matter if they listen to the patient, follow their wishes? Does it matter if they do stuff against their wishes? It's not so black and white. I mean, I'd be the first to stick up for patient autonomy at all costs. But I remember a case where always happens Friday afternoon, right? Before the weekend. This guy was coding. So, what do we do? Because this guy's been here for weeks. His heart doesn't work. He's on IV medicines. Can't leave the hospital. Seems pretty miserable. Actually, the heart failure doctor just spoke to him recently about this. And he was changed to do not resuscitate. So we shouldn't be resuscitating him. But that's all hearsay because nothing was changed in the computer. There's no documented. You can't reach the doctor. So what do we do right now? We did everything. He was intubated for a while, spent a bit of time in ICU. Not surprising because you're in a hospital for a month. Heart doesn't work again. But guess what? He survived. And I happened to just see him clinic a few months later. And I asked him, if you don't mind me asking, how do you feel? I mean, because afterwards we figured out when that doctor came back that he was a do not resuscitate. We went against your wishes, saved your life, and now you're here in the clinic. Said, I like it. But he had a good outcome. So is that fair? Of course you have a good outcome, you like it, right? If you have a bad outcome, then yeah, you wouldn't like it. And I think that's the difficulty. Who determines this? Good outcome, bad outcome. It's not me. It's not the patient. Right? Now with uncertainty, who makes decisions? Doctors often decide they don't want to do stuff. It's too risky. When I say doctors, I mean surgeons. Medical doctors don't seem to have the ability to do that. Whether they lack guts or courage or they don't think it's appropriate, what have you, they don't. Yeah. So I have venture to say it's patience. Patients should be one making these decisions. Because we don't know the future, right? You go eat at a fancy restaurant. You may like it. You feel it's overrated, but you pay the money. You made a choice. And that's that, right? You may regret your choice, but you made a choice. And we believe you should make a choice, right? We don't think that anybody should force you to eat at this restaurant, even if it's highly reviewed. Even if you liked it, you probably wouldn't be happy that you were forced to eat there and pay for it. But in the medical field, it's a little bit more complicated because outcomes aren't so simple. Could be good today, not good tomorrow, better the day after that. It's always fluctuating. So what do you say? How do you look at your life? People try to preserve a story, shall we say. My patient will want to make it through Christmas and then go then. It's like, well, with your widely spread cancer, that's something you may want, but you have no ability to make it happen. I mean, neither do I. I mean, there are crises who will make it happen. There's people with widely spread cancer that aren't dying. They're just very, very uncomfortable. If they want to keep on going and just be in pain, that's their ability, right? I had one guy like that. He wanted to make it to his, daughter's wedding, so he kept on persisting. He made it. He actually didn't go because couldn't walk, and that doesn't look too good at a wedding apparently. But he made it. But his case wasn't so much that he had some medical condition that was going to stop his heart or his lungs. But he was in so much pain that most of us thought he should just take his pain pills and be comfortable. But no, that's his choice. But in this case, my patient today, she doesn't have a choice. Her body's going to give out sooner rather than later. But it's her decision. And I feel that's very important to abide by it. Not respect it, but abide by it. Because it's their body, at least in America.